So this is an 85-year-old patient that came to the office for his annual wellness visit, taking multiple medications, and upon taking a further review of his history, he said that he felt very fatigued, he was dizzy, he was lightheaded. And those are very scary words to hear from an 85-year-old, because to me that means possible fracture, right? So we were very concerned about that, but thankfully up to that point, he had not had a fall yet. Multiple comorbidities, he had several providers involved, and that day in the office, his blood pressure was 102/68. Again, made me very nervous, made me twinge a little bit. And we don't have to go through the whole medication list, but take my word for it, there are 11 medications here, out of which I would say 9 of them are prescription medications. The rest was self-administration.
So Shanta's going to give us a little bit more of a community dwelling approach. She does have a very significant long-term care experience, but she's mostly now in the community, and I'm long-term care and the post-acute. So this is a resident that I met. We have a practice of 5. I work with 5 other colleagues, so somebody did the admitting orders, and then I was the nurse practitioner going into the sub-acute facility to do their initial assessment, which that's another topic, right, the physician versus the nurse practitioner. But, so this was a 91-year-old male, and to say he was a mess, after having a hospitalization for a urinary tract infection with sepsis, he was agitated. With the staff had almost attacked me when I walked in on the unit. Peg, you've got to do something. It's, he is agitated, he can't sit still, or he's slumped over. You need to do something. And of course, things are always worse in the evening. You can see his past medical, including neurogenic bladder and just having that UTI. So we had poor response to the quetiapine PRN. I know, don't judge me yet, we'll talk about that later. You can see his past medical, and then we'll talk after we give you a little preliminary information about how we manage the care. And again, here, now I won, Shanta. I had more.
You won.
I won. Again, I'm still doing it again, right? I'm still the highest number. So this resident had 13 medications coming in.
Okay, so where do we begin, right? And that is our challenge. We want to help our patients. We want to give them what they need. We want to follow evidence-based guidelines, but at the same time, we know that a combination of a lot of these medications are very toxic to our patients. So generally in the literature, polypharmacy is defined as the regular use of 5 or more medications. And I don't think any of you are sitting here that are going to say 5 medications. 5 really is not that much, right? If we look at a lot of our older adults, 7 to 8 or more, and in long-term care facilities, even more. So why do we see so much polypharmacy? Well, I think one of the biggest factors is how the amount of comorbidities that our patients have, right? Those multiple complex conditions. Rarely, do you find an 85, 90-year-old that just has isolated hypertension or, GERD or just a BPH. There's usually multiple comorbid conditions, and you know that if there's a problem, there's a pill, right? 2 problems, 2 pills, and the list goes on and on and on. And then a lot of these medications, they work very well. These drugs are efficacious. We know that they can achieve, the desired outcome. And then we have those evidence-based practice guidelines that recommend their use, right? So think about our heart failure patients. You have heart failure, you're going to either end up on an ACE or an ARB, you're going to have, a diuretic, you might have an, aldosterone antagonist, you're going to have a beta blocker. So just by one diagnosis, you're going to end up on multiple medications, but how can we not give that to our patients, right? Because we know it's evidence-based. And so sometimes it's not even intentional, but just because of their comorbidities, we see those numbers rising and rising.
And things that just keep adding is certainly our fragmented system that doesn't talk to each other, our multiple providers, how about the cardiology, nephrology discussion, right? When you have someone who has complex issues, multiple pharmacies, the hospitalizations. We really have to figure out how to do that reconciliation better. I reduce medication, someone goes in the hospital maybe 8 months later, and then they come back on that same, even if it's more, even years, a year or two later, they're back on that same profile. No one took a look at it. They just looked at what they were on from that previous hospitalization, and then I have to start all over again.
Absolutely.
And our patient and family expectations, Shantha and I lived the dream. We worked with veterans, and it was a great joy and an honor to do that, but their expectation on what they should be getting versus what we felt. And hopefully we're going to give you a really good perspective on this is pure patient-centered care. If we're going to do this right, it has to be patient-centered, and we'll talk more about that. And then that prescribing cascade, right? The side effect of one drug requires another drug, and we need to be careful and mindful of that.
Absolutely. So again, to describe the problem a little bit more, a couple of decades ago, maybe 25% of Medicare enrollees were treated for multiple chronic conditions, but multiple chronic conditions are on the rise, and as of 2015, over 50% are treated for multiple chronic conditions, and 36% are receiving that 5 or more medications, so they're in that polypharmacy, criteria, and they're taking non-prescription medications. And Peg may not see this as much in long-term care, but I see this a lot in primary care. There's a myth that if it's over the counter, it's generally safe. And we have to, continual education, right? And as I mentioned, in skilled nursing facilities, long-term care facilities, the average nationally is 7 to 8 or more. And Peg and I always say, oh no, it's definitely or more. It's not 7 to 8. And then the issue of multiple pharmacies, again, we see that with community dwelling older adults. They might fill one prescription here, and I always caution my patients, stick with one pharmacy. Sometimes it might be a convenience to go to another one, but you want to make sure that they have your comprehensive medication list so that if something is prescribed, you're on a medication and an antibiotic goes in that might prolong the QT interval or something, severe, the pharmacist hopefully will catch it because we may not, right?
Right. I have that long-term care patient who's got the drawer. So we still have that. It's a little bit,
true.
It's a little, right, but it has that drawer filled with the Advil, the extra Tylenol, the Imodium.
Just in case.
Yeah. So we have it a little bit, not as much as you do.
Polypharmacy.
Yeah, so we have our medication problems, right? Top 5 cause of death in the elderly, contributing to also adverse drug. Independent risk factors for adverse drug, hospitalization, nursing home placement, which any of you have done an admission into long-term care, you see that medication profile. Highest number I ever had was 36 patients, 36 pills, I'm sorry. There's no way I could even start with that, Hypoglycemia, if anybody went to the talk yesterday, that stress of hypoglycemia in our older adult, falls, fractures, pneumonia, malnutrition, death, independent risk factors, pretty amazing.
Absolutely. And then, Peg and I looked at some of the other factors, and the complications related to polypharmacy, and we said we're really seeing 2 different things here. We're seeing a patient-focused side, and then we see a systems and provider focus. So what are some patient-focused risk factors? Well, like I mentioned, that multiple medical complexity and having those chronic medical conditions, the multiple providers that are involved. And I have to tell you, it shocks me after all these years how patients will go to specialists and they don't do a thorough medication reconciliation. They're not aware that someone has already prescribed them a medication with anticholinergic properties, and then you start another one, and now you just have this mess, and we wonder why our patients fall and fracture. So that lack of communication, and again, I find that it was easier in facilities because we could get a hold of our, providers, our, specialists. In community dwelling older adults, I have patients that come in with a list this long, and I see Dr. Jones, and I see Dr. Smith, and I see a doctor for this, and I see a doctor for that. I may know some of them I don't. How do I get a hold of them? Where do I begin to even communicate, with these other specialists to say, hey, they're taking an antiplatelet and an anticoagulant together and their hemoglobin is 9. What are we going to do about this, So it becomes really hard, when you have multiple providers in there, and then residing in a nursing home, right? We know a lot of our long-term care patients, they're very frail, they have chronic conditions, hence they ended up in a long-term care because they need that extra help. And we find that the number of medications, just as a result of residing in a nursing home, they have a huge number of medications. And then the other patient-focused problem that leads to complications is that self-medicating. And I mean that in two ways. Number one, self-medicating, where they go over the counter, just get whatever's over the counter and they think it's okay and that it has no interactions. And the other one, self-medicating, meaning self-administration, where you have patients that have memory issues or, even a mild cognitive impairment and they're taking medication. So did I take that this morning? Maybe I'll just take another one just to be sure, And so, or maybe forgetting to take something.